All right, everybody. Hi, my name is Yorgos Antoniadis. From St. George's. Um, Today I'm going to be doing a presentation on a case report that I published earlier last week. If we can go back, I just want to introduce the physician that's going to be with us. He's running a little bit late, but he'll be stopping by shortly. Dr. Samir Ruxmohan. Many of you probably know him. He's as mentioned in the slides, he's a physician partner who's provided like 6+ publications. He's board certified in neurology and neurocritical care. He did his residency at Larkin, fellowship at UT Southwestern. He's currently working in Dallas. He's a neurocritical care doc, and this case report is has to do with neurocritical care, so he could provide some valuable insight to the presentation. Okay. Um, so this presentation, for cerebral brain abscess, mimicking psychiatric presentation in HIV positive patient with post-traumatic stress disorder and bipolar disorder. So as mentioned, this case is something that was a patient that was seen under my care at Kings County Hospital. It was written during my psychiatric sub-internship, and the case includes a multidisciplinary approach. So um, I really enjoy like psychiatry and like I like neuro as well. But I enjoy psychiatry as well. And it was interesting that this patient had at the beginning had like a psychiatric picture, but then after further analysis and further like management, it turned to be something that was neurological. And because of that, it needed a multidisciplinary approach, right? So it included psychiatry, neurology, neurosurgery, and medical team. So next slide. So patient background. Was a 47-year-old HIV positive African American woman, history of bipolar disorder, PTSD, and anxiety. Um, Up to this point, the patient was regularly adherent to medication and psychiatry outpatient visitation. So she was pretty on top of her regimen, taking her medications for her past psychiatric history. She presented to the psychiatric ED with altered mental status, catatonia, and disorganized behavior. A little bit prior, so just giving you guys kind of the background prior to her admission. So basically, the patient received a home wellness check via like telephone call by the outpatient psychiatrist because she missed a couple clinic appointments, which was unusual for her presentation because, as I mentioned, she was pretty on top of her medications and her appointments. So when the psychiatrist called, the patient was disoriented to person, place, and time, and the psychiatrist noticed that her voice was like irregular, it had like fluctuations, and it was like a hoarseness that wasn't present prior. So the psychiatrist called the mobile crisis unit to visit her residence. When the crisis unit came, they noticed that the patient was not taking her medication. She was disorganized, rigid, malodorous upon entering with blood-soaked underwear, and not really answering uh, any like prompts or any questions that were given by the team. As per the son denied any worsening of manic or psychotic symptoms, hallucinations, suicide, homicidal ideations, worsening of depressive symptoms, which aligned with the like chart review and everything that the psychiatrist had. Um, because of her state, because of her psychiatric state at that time, she was brought in. So the mobile crisis unit called the 911 for her to be brought in for psychiatric evaluation. So when she came into the hospital, the patient was mute but cooperative. She seemed internally preoccupied and slightly disorganized. Oftentimes she would like look to her left or right, hearing voices, for example. And she was internally preoccupied. She wasn't able to really grasp the situation that was going on during the triage. However, she was cooperative. Um, and then further attempts led to even less responses. She didn't make eye contact, didn't produce any spontaneous movements, and wasn't responding to questions. Now these were symptoms that were never apparent in her past psychiatric history. Um, so from the emergency, she went to CPEP. CPEP is like the comprehensive psychiatric. It's pretty much the Psych ED in New York. I think it's called different things in different states, but she was in CPEP. Patient became even more catatonic, became mute, was self-urinating on herself, and had a new onset of tremulousness. The laboratory findings of AKI and hypernatremia ultimately led to a transfer from the Psych ED to the main emergency department again because her electrolytes were imbalanced and therefore they deemed it also a medical situation, not just a psychiatric. Right. Um, by the end of the day, the patient developed more neurological symptoms. So patient developed cogwheel rigidity and her condition significantly deteriorated. She was no longer responsive at all. Um, she exhibited asymmetric pupils with bilateral myoclonic jerking, which warranted her status warranted emergent intubation. After that, they noticed that patient had new onset hypertension with increased pulse pressure and bradycardia, which raised concerns for Cushing triad uh, and ICP. Because of this, they decided um, that it was necessary to do further imaging, right? Now I'm going to talk about this later in the discussion, but in terms of this situation, her neurological symptoms warranted this increase in like increase suspicion and to do imaging. So it wasn't until the neurological symptoms occurred that the patient went for imaging. The CT scan of the chest was also completed, which found an AVM in the left posterior lung base and pulmonary artery. Next slide. So this is just an overview of the symptoms. So as mentioned, at the beginning, she had more psychiatric etiology, so disoriented, bizarre, confused over the phone. And then when she was triaged, she became more mute, cooperative, but internally preoccupied, unable to make eye contact. She had symptoms of catatonia, which included like mutism, rigidity, and tremulousness. And then the abnormal results via the labs brought her to the ED, the general ED. Um, which then she had a further decline, and then other neurological symptoms like autonomic symptoms, for example, like pupillary unresponsiveness, asymmetric pupils, myoclonic jerking, et cetera, et cetera. Okay. So when the imaging occurred, um, two images that were important were the non-contrast CT and the MRI. So as you can see here, um, in the non-contrast CT, you have a large heterogeneous mass about the left frontal lobe with stable local regional mass effect and associated moderate vasogenic edema. And you could see it clearly, right? You could see the midline shift in the images um, of 9 millimeters with subfalcine uncal herniation and then a right frontal subarachnoid hemorrhage. Um, and then the ventricle effacement. On MRI, the CT warranted further evaluation with an MRI. So we found.
So why don't you pause here? I think this is a great slide on the imaging. So here you see a hypodensity, right, on the CT. Now, we have a lot of people that I've done research with here on the meeting. Why don't we talk about what are your differentials right here first, right before we jump to the MRI and the answer, right?
Mhm.
So you said hypodensity and you see a lot of vasogenic edema. So I guess what are the different types of edema patterns? And anyone here on the meeting can speak about this.
When I see like a CT like that, it kind of makes me think that there's like a hemorrhagic stroke, especially with like the hypodensity. Um,
Why would you say
but
hemorrhagic stroke? I thought usually hemorrhagic strokes show up as white or acute in nature.
oh, I thought it was darker. Okay, maybe I'm wrong. Yeah.
So
So we're thinking about a tumor
Yeah.
here. It's a vasogenic edema. So, or an abscess?
Good. So tumor, abscess. What about an old stroke here? So
Yeah.
I one instead of hemorrhagic stroke is maybe an old ischemic stroke, right? Or a subacute stroke, right? That has swelling or cerebral edema surrounding that.
Mhm.
So that's the first thing, right? Say you have nothing besides the symptoms of myoclonic jerking, sure, asymmetric pupils that kind of preluded you. Did with the psychiatric? I wasn't here for the psychiatric symptoms, but were there any rule out of serotonin syndrome or NMS or anything like that? Were there any drug interactions in the beginning?
No, there wasn't. There was no indication of any of those. The patient had, just to briefly go over it, the patient had like catatonia and was internally preoccupied, things that were not apparent. Yeah, just go into that summary slide. I think that's a good one. So patient was just presenting as like bizarre, but it was unlike her regular presentation of her PTSD. And then
Well,
yeah, so it was just more so like she was not adhering to her medication. They did the wellness check and she wasn't taking her medication or
I
anything
guess
like
I
that.
just thought I heard you say rigidity and things like that. That's why I always ask that question first, right, with psychiatric complications.
Definitely, yeah. And then once they got to the hospital, then the patient started exhibiting these more neurological symptoms like the rigidity, asymmetric pupils, and those.
Okay. Go back to your imaging slides. So sure, we said tumors, we said abscesses, or maybe an old stroke with edema. Now, what are the different types of edema patterns that you guys know of?
Like vasogenic cytotoxic, is that what you're?
Right, exactly. So what does that mean, or how do you tell the difference, right? In this picture, looking at it, how can I tell the difference? Anyone can answer.
I was gonna
So
say like this, sorry,
I
like the
think
surrounding. Sorry, go ahead, Marco. Sorry.
I think the vasogenic edema will respect a border, so it will not cross from white to gray matter. The other one will.
Very good. So think of vasogenic as finger-like projections that follow the vessels but don't cross into the white matter of the brain. The white matter is on the outside, right? In this picture, if you can circle it, the outside of the brain, and the inside is gray matter, right? But it's in the spine, it's flipped. It's actually opposite, right? So here in the brain, you have vasogenic edema. There's also hydrostatic, right, or interstitial edema as well. Do you know what that looks like? So whenever you have hydrocephalus, you have buildup or fluid around the ventricles, right? And that's sometimes a component of interstitial or hydrostatic pressures from the fluid shifts. Now, I think somebody asked about the midline shift, or what was that about in the chat? Sorry, I didn't see that.
I think they were responding to the question for the differences between edema.
So I think this is a great point right here that subfalcine herniation. So I think it's key right here to learn the herniation syndromes, as you see here. So in the ACA territory, you see a sort of a left to right midline shift, right? So it's affecting your ACA vessels right there. So that's why he's saying subfalcine herniation right there. The falx is what's in the middle right there.
Mhm.
That shift on the ACA territory, you got to watch out for leg weakness and things like that in this situation. So in this picture, how did y'all, just by looking at this before you jump to MRI, right? There's so many things to do, to think of, to intervene on. So I guess what were your next steps immediately in this moment?
Um, I mean, if I see that, I would think to do an MRI to like investigate it more thoroughly, right? I mean,
But the patient's also declining at the same time, right? Were they protecting
yeah,
the airway, right? Because there are
yes.
radiation syndromes, there's a little bit of hydrocephalus, there's vasogenic edema surrounding, right? So you have a lot of opportunities to intervene here in this moment critically, right? So you could use steroids, you could use hypertonic saline, right? There are things to be able to intervene on acutely here, especially since your patient is declining.
Hmm.
All right.
Yeah. And then the next slide, if we go, we'll talk about the treatment approach, the management. Yeah. So this is just the visualization of the AVM. So if we can go to the next slide. Yeah, so the management. So the patient was given dexamethasone and mannitol administration due to increased ICP upon admission. Um, After that, once they realized that there was the abscess, surgical aspiration of the abscess in the left hemicraniectomy, they cultured it and found strep viridans,
Okay,
which which sorry, continue. Yeah, sorry, my bad.
super important. So
Yeah.
how did you come to the conclusion on the MRI? So go back to it. How was this the abscess, or I guess tell me what study did you order next after your CT?
Um, after CT and MRI?
So your MRI has to be with and without contrast, right?
Yes, yes.
So if you're looking in the furthest right picture, you're seeing something. What is that finding, that pathognomonic finding that we all know?
Like
Like the capsule?
What is it?
Like the capsule around the abscess?
Yeah, what is that?
Like a ring
Ring
enhancement.
Ring.
Yeah.
Exactly. So now what are your differentials for ring enhancing lesions?
The toxo, especially an HIV patient.
Talk so good. What else?
Um,
So if you just Radiopedia or Google right now, just ring enhancing lesions, generally you're going to see a whole slew of lists, right? We can't just jump to that this is immediately exactly CNS lymphoma, perfect, right? So there are multiple differentials here for a ring enhancing lesion, right? So there's
Mhm.
got to be more to the story. Does the patient have, like you said, now finding out travel history, HIV underlying status, all of these things? Before we jump to strep viridans, it's nice that you found the strep viridans. Now, my question is, because I know we've done a granulomatous amoebic encephalitis case with CRG. So, were there any underlying predispositions, such as nasal fractures or swimming in lake environments, that would have predisposed this patient to having this?
No, not reported. Also the patient was when we went to see her in her wellness check, she was mute and not answering questions, of course. So there was no indication that she was doing any of that prior to, but given the strep viridans, we obviously all learn in step, like dental procedures and like things like that that could be uh a manifestation of strep viridans causing that.
Good. So, what did you, after you found this image, you said steroids, and what did you treat the strep viridans with?
Um, Honestly, I wasn't there at that point. That was when I finished my rotation. I don't know what the strep viridins with antibiotics, of course, but
General treatment for cerebral abscess.
yeah, so like antibiotics, of course. And obviously the aspiration of the abscess, which made us be able to find the strep viridins. Yeah.
Said this patient got a hemicraniectomy, a removal of the skull because the pressures were too high.
Mm-hmm.
I see.
Yeah. Okay. Um.
Ask questions.
So,
This is a good. I know you want to keep going through your thing, but I think have an open forum for discussion. Do people have questions? Because this is actually the most interesting part for me from a neuro ICU standpoint of how the patient is now having all these complex neurologic issues. Myoclonic jerking. So were you concerned? Did you want an EEG to further rule out or indicate to you that the patient was seizing here?
I think that given the how quick everything kind of happened, I think that once they found the abscess, I think that and they came to the conclusion that it was necessary to do the craniectomy and the abscess, the removal, the aspiration. I think that took precedence at that time over doing an EKG to determine because they kind of found it in the imaging and they thought, this patient is rapidly deteriorating. So I think that it was more necessary at that point in time to do surgery,
Okay.
right?
So you never put a prophylactic dose. You said myoclonic jerking, so you never treated it or put a prophylactic dose of anything here, correct? Give me 1 second. I've got a physician here.
No worries. Um, they might have done an EKG. Well, I wasn't there at that point, but they might have done an EKG. I think I'm just gonna continue if you guys don't mind. Um, so in terms of the management, so I completed a left pulmonary artery angiogram, a selective and super selective left pulmonary artery branch catheterization, embolization of the AVM. As mentioned, the the malformation was kind of treated or managed after the more relevant case of the brain abscess at that point. And then going along with the EKG findings, as you mentioned, during the recovery after that, the patient had a witness seizure that lasted 2 minutes that self-resolved, treated with lorazepam and levetiracetam, followed by brief episodic tachycardia with the heart rate at 190, which resolved, and then the patient didn't have any more seizures after that.
So were they placed on continuous?
Yes, I believe so.
Okay.
Um,
Remember, this is an important point that patients can have non-convulsive status, right? They are not actively shaking. So it's important to put these patients on continuous to make sure they're not actively, right, having non-convulsive status. Because you have predilection, right? You have an abscess that's near the cortex. They could seize and go into status at any point here.
Yeah, for sure. Okay, and then in terms of the outcome in the recovery, patient had gradual improvement in mental status and motor function. Um, she was still tubed, she was still with tracheostomy tube. But she was able to, like, when speaking to her, she was able to like nod yes or no to an extent. Her asymmetry in her pupils was normal at this point. She was able to respond, via, like nodding and things like that. At that point, she was discharged to a subacute rehab facility. And as mentioned, she followed simple commands and improved spontaneous movements from the left side, but the right side did still remain weak.
So how many days was she in the ICU or in the hospital for this abscess treatment?
She was there for a while. I think she was in the hospital for, I think, 2 months.
Mhm.
I think she was in the hospital in total for 2 months, but that was also because of other complications that she had. As mentioned, she had a seizure, so that kind of wanted to get, still wanted to make sure they're okay before sending her to subacute, just in general, because it was, you know, they had to manage the craniectomy and things like that. So,
What did they do to the pulmonary AVM finding?
yeah, so they actually did embolization for it. Sorry, you were talking to the other physician, yeah. They did embolization for it after the neurosurgery.
Okay.
So I just wanted to go like a brief overview of brain abscesses. I know we talked about it, but it's a localized collection of pus within the brain tissue, usually caused by bacterial or fungal infection. Here are some risk factors. So immunocompromised patients. So in this case, HIV positive, or those that are on immunosuppressive agents. They're higher risk. AVMs, they can act as a conduit to enter the bloodstream, leading to infections and abscesses. Direct spread from adjacent infections, and then some bacterial and fungal etiologies as to why brain abscess can occur are listed here. And then, yeah, so the symptoms, diagnosis, and management are pretty in concordance with how we manage the patient. Yeah, so we can go to the next slide. So discussion, just the clinical challenges. So in this case, you have a situation where you have a psychiatric patient who first appeared as having kind of continuity from her psychiatric symptoms that were actually um something underlying going on, aka like the brain abscess. So I believe that the importance of early neuroimaging in patients is important, especially in this case where you have an atypical kind of psychiatric symptom that you might attribute to the patient's past psychiatric history, although there might be something, as mentioned, underlying going on. So I think that it's important to um, look for other causes that might not be so typical, and obviously, like, for sure, do like neuroimaging at an early period to kind of rule in or rule out things that you might not think might be present at that time. Um, as mentioned, it was a collaboration between neurology, psychiatry, and neurosurgery, which is essential. And then effective surgical and pharmacological interventions were critical in patients' recovery. And then once again, distinguishing between psychiatric and neurological causes in immunocompromised patients. So there was three relevant cases that I found during this presentation. So the first one was a psychiatric admission to an outside hospital. CT was the only reason why CT was done. Like the patient had depressive symptoms with suicide ideations, but the patient had previous craniectomies. So the only reason why the imaging was done was due to the previous craniectomies, at which they found an abscess. The surgical intervention was done within 21 hours of admission, leading to effective management of the epidural abscess and return to baseline. Fukui et al. Um, Similar had depressive state, presented with chronic illness but without any typical symptoms such as headache or fever. The they only realized that the patient had an abscess and it wasn't due to depression, let's say, because when they gave like antidepressants and medications for depression, they were ineffective. The depressive state was eradicated with antibiotic treatment. No surgery was needed, and abnormal MRI findings resolved over 7 weeks. And the last one, Mahato et al., ruptured cerebral abscess presenting as catatonia, which is similar to our presentation. Patient had cataplexy, mutism, and unprovoked agitation for 20 days prior to recognizing a massive epidural abscess. Once again, this abscess was only recognized because of a lack of response to psychiatric medication. However, this patient's um, progress was worse. So, despite recognition of the urgent neurosurgical treatment that was necessary, she succumbed to her illness prior to the surgery even like occurring. So, I think that just goes to show you how important it is to really catch on to something like this, especially when they have like psychiatric comorbidities. I think it's important to catch on to this very quickly because even with our patient, it could lead to rapid deterioration and in the last case right here, even death.
So I have a question slash, first of all, this is like a great thing to bring up because I feel like a lot of the psychiatric patients you wouldn't really think to like, oh, let's do like brain imaging. So I guess like my question is, this can go for, Dr. Rux or you, Yorgos. What are some like red flags, symptoms that we sort of look for to say, okay, like maybe this is more than just a psychiatric symptom and we should do further imaging?
So for me, I think that in terms of our case, I mean, so the first two cases that are in this slide, they didn't have any of the like neurological deficits, or maybe they weren't as prominent. So as mentioned, like the only reason why they did the imaging was either because they had a previous craniectomy or because their psychiatric meds didn't work. So I think that I think taking that step from it being like a psychiatric manifestation to it becoming more than just that in terms of like, you know, like we mentioned, the cogwheel rigidity or the asymmetric pupils, I think that is more of an indication to like look further into it and reveal maybe there's something more going on in the brain. Dr. Rux, do you have anything you want to add to that?
A lot to say about this. So I have a couple things. You've seen autoimmune encephalitis, for example, like NMDA receptor encephalitis. I don't know if anyone's seen the movie Man on Fire, but the symptoms were purely behavioral, right? They were psychiatric in nature. But I think to red flags wise, to answer that question, medical clearance first, right? Before we even think psychiatric meds, before throwing on antidepressants or anything like that, right? So first thing, medical clearance, right? Have a CT on most of these patients just to make sure that nothing intracranial is going on before you just attribute to, this is depression, this is bipolar, this is schizoaffective, right? But autoimmune encephalitis can present with just behavioral purely manifestations and no neurologic, focal deficits. There is PANDA with Streptococcus species in kids. I don't think, has anyone ever heard of that? In kids that are purely behavioral manifestations and reversible with treatment of strep species. So it's hard to say. I think when things are not looking right, like these saying, right, they tried treating it with SSRIs, things like that, didn't work. And then, it got so severe that all the neurologic abnormalities started presenting. What other questions? This is a good, interesting discussion. So I think there should be a lot of questions here today.
No, with the initial presentation of the patient, one of the things that like I started thinking about was like extrapyramidal symptoms or syndrome. And I was just like wondering what this patient was on and like if they had recently changed dosing. And
No.
then I also know that she was HIV positive, and you know that obviously can increase your risk of developing an abscess. So I was wondering if she was currently taking her medications for the HIV meds as well.
Yeah, she was. So I don't it's listed, but I didn't have it in this presentation, but she was taking just medications for PTSD. So I think she was taking her SSRIs.
Mm.
Um and her HIV was controlled to my knowledge. She was adherent to her HIV medications. But that's all I can give you right now without looking more into the case right now on the presentation. But um as mentioned, like the doctors and the psychiatrists like didn't have any indication that she was off her medication by any means or anything like that. And the fact that they went in and found that she was like not adherent to her medication was more so the fact that of her like status at that moment, of the fact that she was, catatonic, and you know, she had blood-stained like pants, meaning that she wasn't like, she was on her period and not necessarily like keeping herself, hygienic and things of that. So, um, but in terms of like her medication, it seems as if that she was adherent up to that point.
Hmm. Okay, cool. Thank you.
Yeah, no worries.
I wish we could have seen a little bit more post operative imaging from the hemicrania, right, and the resolving of the cerebral abscess. That's one thing I think I didn't see.
Yeah. I have it. I have it. I can send it to the group or to you or whatever after. I just didn't put it into the slides, but I do have the imaging.
Can you pull it up right now?
Honestly, it's in my emails right now. I don't know exactly where it is now.
Oh, okay.
I'd have to actually scavenge for it. So I did this like a few months back. So yeah. Anyways, that's about it. The conclusion.
I have a
Sorry.
question.
Yes.
So regarding her HIV status, I don't know if everyone's aware, I work in Jamaica. So what we do when we have patients with HIV is that routinely we do their CD4 count as well as viral load, even if the patient tells us they're adherent to their medication.
Mhm.
Was that done in this case? Because that would have kind of cued you in that, okay, even though she says she's taking it, she's not really taking it. So you'd have to kind of look more for infection in a case like that.
Yeah, yeah. I don't know her CD4 count exactly, but she was doing regular checks with the doctors to make sure that her CD4 counts weren't dropping significantly. Um, but I can't give you the exact CD4 count at this time right now,
Okay, that's fine. Thanks.
of course.
Dr. Rox, I have a question regarding the seizure prophylaxis. So when you see a image like this, do you, even though it's an acute state and everything is happening so fast, do you put a patient in a prophylaxis like levetiracetam, like Keppra or something like that, and then do the EEG, or do you do the EEG first to see if they're in status? Because this one wasn't catatonic and having all those symptoms.
Great question, man. So say this patient is coming to you, right? You get imaging and you see this hypodensity, right? And you hear the story of myoclonic jerking. That's all you have, right? You're going to treat it as such. You're not even going to put a prophylactic dose. You're going to treat it as status. Treat it. So what we do first, right? I guess we should run through a status management quick.
Keppra first.
So benzos first, right?
Benzos.
Tier 1, right? They're if you guys want to write this down, the ESETT trial, ESETT.
Mm-hmm.
The ESETT trial tells you tier 1, tier 2, tier 3 therapies. Tier 1 therapies are benzos, right? So when patients come in via EMS, right, they're given intranasal or sometimes IV Versed, right? Or benzos in the hospital, you're going to be giving Ativan, right? So how much Ativan?
One. It was
Not
one.
enough, man. So usually in status, you need to start with about 4 milligrams of Ativan.
4 milligrams.
Thing, but you can increase to 2, add 2 and escalate as you need up to about 8, usually on most patients. Okay. Now that's the first problem, right? You know, if you're not neuro, you don't really know, right? As hospitalists, they don't know. They get confused and they're like, oh my God, what do we do? The answer is about 4 milligrams. Appropriately load, right? Benzos first, okay? If you're concerned for status, right? This patient was having myoclonic jerking visibly with a hypodensity with cerebral edema. So you have to treat it as such. So I don't think, sure, if you stop the seizing, but have the continuous. You need to treat before you even get an EEG. Just suspect, right, in these situations. Anticipate before you're waiting. Because when you go out into real life practice, because I'm actually practicing now, you may not be training at academic centers where you always have the luxury of the EEG or continuous right away, right? You're going to be in community settings or different settings in general, and you're not going to have the ability of continuous or routine EEG right then and there. So you have to manage on the fly quickly and acutely. Now, after benzos, what do? You've appropriately loaded about 6 milligrams of Ativan. The patient is now yours in the neuro ICU. You guys are now the students/residents on the case. What's your next best step?
Do we give steroids?
Steroids? I wouldn't give steroids.
You will go with phenobarbital?
Phenobarbital? What's
Yeah.
barbital used for? What is phenobarb?
It's anesthetic, no?
It's a barbiturate.
Yeah, okay.
So let me ask you this first, since you guys are all on mechanisms right now. So benzos act on what to be able to stop seizures? What is the seizure? Let me start with that.
It would work on GABA.
Good. So it works on the GABA channels, right? Seizures are hypercortical firing activity of neuronal function that's going, right? So acting on an inhibitory channel will help suppress that activation. So that's why, benzos are first. What are barbiturates?
They work on GABA too, right? But a different like receptor.
Good. Receptor. So there's GABA A and there's GABA B, right? So GABA B in this situation. But no, I would not be using phenobarb. Phenobarb is typically used for alcohol withdrawal.
Okay.
Is this when you give like after the benzos, is that when you give another like a Keppra, like I mentioned, or like valproic acid after
Right.
that?
Now you're on your tier 2 therapies. So tier 1 was benzos. Tier 2 therapies are your Keppra. Okay, so the patient's yours. You're the resident on the case now because you guys are going to be transitioning to residency soon. So the question is, what would you like to do? How much? So would I give like Keppra 500 and just hope for the best, or is there an appropriate loading dose instead?
Yeah, so you would give
1,000?
you would give a loading dose first. I think like 40, I think.
All right, so know these, all right? These are very important. Keppra is a 60 mg per kg loading dose with a max of 4.5 grams. So you can start with Keppra. What is the untoward side effects of Keppra?
That they can be aggressive? Is that one? Keppra? No.
Aggressive, they can have mood side effects of depression. So ding, 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 you used Keppra in this situation to treat your prophylactic seizures in your case, but the patient was initially presenting with depression or having these, psychiatric symptoms. Probably not the best medication to have used in that situation.
Valproic acid instead.
Okay, so what about Depakote? How would Depakote help here? Depakote is also part of tier 2 therapies. So they've done this trial, the ESET trial that you guys will read later on, that assesses back-to-back of competing against Keppra, Depakote, and fosphenytoin or Dilantin, right? And they looked at these three, they're all equivalent. So it doesn't matter which ones you use first in status, they're all equivalent. So Depakote is something that you could have used a 2-for-1 special to be able to not only control your status or seizures, but also mood stabilization here would have been the better choice to load appropriately. But what are the untoward side effects of this medication?
Sorry, of Depakote?
Yeah. Valproic acid, for those that don't know. Good, very good. Liver.
Yeah.
Liver. So you need to continuously check your LFTs, your AST, your ALT. Excellent. Ammonia, because it can drive up the ammonia. can cause more encephalopathy. So that's a problem, right? What about platelets? Platelets is something can cause thrombocytopenia as a side effect. So you need to be able to look for all of these things if you're going to start a dirty medication like Depakote. What's your third? Fosphenytoin. What's that? And and as we talk about this, it's important because you transition your residency to know these doses now, right? The other names and the doses of medications, because this is going to be your license soon to be on the line, right? For everything that you do. And every day you go into medicine, into practice on your own, you're defending your license. And remember that. That's very important because we live in a very litigious society and it's about protecting yourself, right? So that you don't go through malpractice suits. Okay? So what is this? The dosages for status. Somebody put it there as a summary. Good. All right. So what else? So fosphenytoin. Tell me about that. What do y'all know?
It's like a precursor to phenytoin, right, in the body.
Why do we use that over phenytoin in status?
I'm not sure.
Okay, you don't know the answer. Fast acting. Good. Very good. It is faster acting. Correct. What are the untoward side effects, or what do we need to monitor in Dilantin?
Like heart issues, no?
Good. There's cardiac issues, right? So if you're worried about low blood pressure, right? Glad they're in the ICU. Stephen Johnson, sure. Dilantin toxicity, very good. What else? There can be nystagmus issues. So look up Dilantin toxicity. That's always an interesting one. Good. Not for childbearing women. Exactly right. Neither is Depakote. So you have to remember these are all things that you're thinking of actively as you're progressing your care, right? If you have a young female, definitely check pregnancy, right? These are the things that you need to look for so you're not hurting people at the end of the day. So don't just assume, right, that, okay, Keppra was the right answer. It's ask the questions, further investigate, what are the reasons, what we could have done better, what we, did not do well. This is all part of M&M and building your kind of yourself, right, as you move forward throughout your training and as you get to be on your own, is question every decision, every move, because you are defending, right, that medical decision in that moment. All right, so you did tier 2 therapies, Depakote, fosphenytoin, Depakote and fosphenytoin. Great. So say the patient's still seizing on you, still having myoclonic jerking with this hypodensity seen on your CT. What's your next best step? MRI? No, the patient's unstable for MRI and shaking. Sorry.
I guess this is when we get into the phenobarbital or propofol or midazolam.
I would stay away from phenobarb. Just use it in alcohol withdrawals. Don't use it in status. So take another guess.
Propofol?
Midazolam.
Now you're looking at to protect your airway. Absolutely. So if you're thinking at tier 3 at this point, you better get a endotracheal tube in, put it in, and at this point, you're going to need to think of sedation, sedatives. So yes, how much propofol? You're going to be using a lot of when you get on your ICU rotations, you're going to be using a lot of fentanyl, a lot of propofol. Know the drips, a lot of Versed, right? So
3 to 5 milligrams per kilo load, and then 1 to 15 milligrams per kilo per hour infusion.
Great, exactly. So you're going to have an infusion of propofol, but how much do you want to throw on? So say the patient's visibly shaking on you. How much is too much? Let me ask you that. It's a nice dose that you gave me, but how do I know that they're not going to go into propofol infusion syndrome? Chris, what's that?
Isn't that like when it destroys like the mitochondria, and then you
Very
start
good.
to green
What-
urine, something like that?
Of Chris, tell me what you see.
Um,
Heart with the kidneys.
yeah, the kidneys get destroyed, and then don't you see like green urine?
That's a side effect of propofol is green urine, but what else? So write down PRIS for you guys to look up later. This is very important because you're going to be using a lot of propofol in your careers as you progress in the ICU. If you guys go on ICU rotations. What else? You will in your intern year at least. So, okay, you put the patient on Propa 40. Let's just start there. They're still seizing on you. What's the next best step? So I'm showing you the sickest of the sickest. I'm giving you an example of if things don't go according to plan, because that's what's going to happen, right? You learn Keppra, you learn benzos, and then that's it. That's all you learn for neuro. But what happens if it's so refractory to all of these things? And you're in a community setting, you don't have a Samir or anybody to call as an upper, and you're on your own. What do? Ketamine, very good. So ketamine is something that can be used for super refractory status epilepticus, and the studies have been shown good effectivity of that medication. So ketamine is something that can be used. What else? What is ketamine's?
Like another anesthetic.
So before we go there, what is ketamine's mechanism of action, and why is it maybe not a good choice in this situation?
It's a NMDA antagonist.
NMDA antagonist. So what is the importance of that? You can actually worsen the untoward side effect is causing in psychiatric patients visual hallucinations. It can actually worsen things so bad. So this is a problem, right? This is something that we need to watch out for. Maybe not use ketamine in this situation. But it's very good if a patient is an asthmatic and you need bronchodilation or bronchodilatory effects, then ketamine is very good. A lot of people are using Ketafol actually in the ER, which is a mix of ketamine and propofol for procedural sedation. There's a paper on that, so read about Ketafol. What else? So what other anesthetics? Sure, you had a Versed drip. What's a Versed drip? Etomidate, what's etomidate? So stop. Somebody said etomidate. What is that? Speak up. Speak up. Don't even text in the group chat. Just talk. Speak freely. This is your chance to learn.
It's a GABA agonist. I can't speak today.
So what does etomidate, like, why is that important? Like, what do I do with etomidate? Okay, so if I need to assess the breathing status, right? We're worried about somebody's airway. What do I use etomidate for?
It's an induction agent, right? So
An agent, very good. So what does that mean? Why is that important?
it'll put them to sleep, but maybe if you can't get the ET to them, they'll come
What
back.
besides etomidate should I be giving in these patients? Etomidate is not enough, right, to get an airway. What else do you need?
Paralytics.
Paralytics, very good. So you need a rocuronium. What about succinylcholine? What's your opinion on that, if anybody's done any anesthesia rotations?
Fast acting, so within like 5 minutes, it'll be
Right.
completely out.
Toward side effects. We look at the timings. That's nice to look at the timings, but you as a physician should look at apnea. You're trying to get the intubation, so it's okay if they're apneic. They're not.
Secretions?
What?
It was secretions, that one?
Not secretions. Succinylcholine is important because the untoward side effect is hyperkalemia.
Yeah.
So in your neuro population of patients, right, with strokes or things like that that are hemiparetic, and they have buildup of hyperkalemia because they are not able to move their arms or legs, right? That can build up and cause real problems. So actually in your neuro patient population, you want to avoid succinylcholine because of the buildup of hyperkalemia. So great, etomidate should not be used in this situation because you are now going to use an induction agent. You're going to paralyze. You never paralyze somebody that's in active status, because say they're visibly shaking and you solve the problem by them completely paralyzing them, they can still be seizing in their brain, right? But not visibly shaking. So that's actually the worst thing you could do, is to, etomidate, rock, paralyze them in this situation, unless you're getting your airway, of course.
Cool.
So in this situation, you have an intracranial lesion as well, right? So you need to worry about high increased ICP in this situation. So propofol is a good induction agent as well to decrease ICP and to be able to help here in this situation. What else? Versed drip, how's that important? What's Versed?
Versed is a midazolam, so that's like another benzo.
Great, so that can be used here as well. Now, say none of these things worked. What's your next best step? Did you know it can get even worse than this?
I didn't.
It can. Yes, it can. And I had a patient here in the neuro ICU. We had him on pentobarbital. Have you heard of pentobarb? Not phenobarb, but pentobarbital. So pentobarbital is an interesting one. It's a barbiturate. It can be used in TBI patients, actually, to decrease intracranial pressure as well. When you're having very refractory ICPs that are very high in TBI, it's usually tier 3, tier 4 therapies in TBI literature. Yeah, so we had a patient here for 2 weeks, was still refractory, still seizing on the pentobarbital itself. So when they're still seizing up until that point, you need to investigate what is the reason, why, right? Not only is it just to control the management, but to find out why. Ask the question. So what could we do to investigate this further of why they're seizing so much? Say you didn't have this intracranial lesion. Say you have a clean CT and there's nothing there. What would you do next?
The EEG?
The EEG is just showing you that they're having lots of spikes and sharps and lots of activity. What else are you going to do? They're still seizing on you. That's all the information it's going to give you. So what do you want to do next? So you need to look at, firstly, some other control medications. The new ones that are out are zonisamide, Aptium. These are also good medications for seizures that are oral. So you'll have to get a Dobhoff tube or an NG tube into the patient to be able to give that. But the biggest thing here is you've got to figure out, do I need an LP? Is there some sort of infectious or autoimmune encephalitis happening here that we're missing, right? The other thing is you can trial. At this point, when you don't have anything, you need to start trialing steroids, right? Doing an induction of solumedrol for 3 to 5 days. You need to figure out, do I need to place a Quinton catheter line? If the patient is needing a Plex therapy or IVIG, right? These are the things you need to be thinking of. What guns do we have in Neuroland to be able to help here, all right? So that's status in a nutshell of how you should think about it moving forward. Hopefully that helps you and guides you whenever you ever see a seizing patient, okay?
Dr. Rox, I had a question. What are your thoughts on using ECT for a patient that's still like continuously seizing?
Wonderful. I am so happy you brought that up. Did you know that ECT can be used in status? Yes, it can be used. I don't know if there's much data on it, but yes, there are articles out that are showing not only steroids, IVIG, Plex, etc. when things are getting very bad, but yes, ECT can be used. But I'd like to, maybe the next journal club meeting or whatever you guys have, let's see what the data is on ECT therapy here in status. Like, that's very interesting. Very interesting.
That's also a good topic potentially for like a literature review or something.
Absolutely. I don't want to take too much time, but is there anything else you guys want to close? I stole your thunder, man. I'm sorry.
No,
Thank you so
that's-
much, Doctor, to
Yeah,
answering the
it was-
question and the discussion.
Yeah, it was very informative. I really appreciate it. Thank you.
It's
Uh,
moments like this, it creates the opportunity to have that discussion so that you take something out of this, 30 minutes to an hour of just, you learn something, and take it home with you and apply it, right? Look up these things and find out more information of what we talked about, what you knew, what you didn't know, and apply it to your own practice, because moving forward, it's going to be you as your own island. And you can always ask for help. It's always good to ask for help, but ultimately it's going to be your decision making and your licenses on the line. So that's my only advice for practice, as I've transitioned from training now to a new attending, is protect yourself and have reasoning and for everything you do.
Perfect. Thank you, Dr. Rux.
Absolutely.
Yeah.
Yeah,
So
have any like last minute burning questions?
yeah, anyone else have any questions before we move on? Perfect. Well, thank you guys so much for giving me the time to present this case. I'm gonna hand it over back. Thank you once again, Dr. Rux, for joining. I know you're very busy. I appreciate it.
Thanks everyone. Yeah. Have a nice day and good seeing everybody I've done papers with. I look forward to doing more.
Yes, thank you so much,
Of
Dr. Rux.
course.
Appreciate it.
All right.
Thanks. Take care.
Bye.
All right, great job, Yorgos.
Thank you.
And I'm gonna stop recording now. Okay.